Hi, how you doing? I'm Greg Roscoff, and I'm the owner and developer of Muscle Activation Techniques. And I want to welcome you here today. We're going to do a little talk on isolation versus integration, kind of from a standpoint that when we exercise, we kind of have some focus on integrated or functional type training, from myofascial change to just the whole functional understanding of movement and creating the transfer of our exercise into functional movement. And we're going to look at the idea of isolation versus integration, that the isolated parts, individual muscle function and its relationship to integrated motion or functional movement. So I want to thank you for being here. I know kind of a tough time for everybody with the coronavirus and many people not being able to work for an extended period. We've still been, from a private practice standpoint, MAT as itself is a non-essential business, and so we've been kind of shut down from a private practice standpoint for about 4 or 5 weeks. So I know we're all dealing with some issues with that, and hopefully everything starts to mellow out. Some businesses in some states are being able to start functioning again, and so hopefully we give you something today that you can kind of take the concepts and principles to practice when you can get back to work. So again, we're going to talk about functional movement, and that's kind of where I started. I started. I mean, I was a strength and conditioning coach at Fresno State. I have a master's degree and with an emphasis in exercise science, and so I was in the field of training and function. And myself, historically, I had a fractured vertebrae when I was 19. And had a lot of residual problems that related to that fractured vertebrae, and not really understanding, and being in the strength and conditioning field, the exercise field, I didn't really understand the muscle system's role and its relationship to why I was in chronic pain for an extended period of time. Because over time, through compensation and adaptation, by the time I was 25 years old, I had patellofemoral syndrome, plantar fasciitis, SI joint dysfunction. I mean, I was broken down. And literally, I was like, if I'm this bad at 25, what am I going to be like when I'm 50? I mean, I was just, trying to be healthy. And I'm working in the strength and conditioning world, and have a great understanding of the body, I think. But again, as a strength coach, this is back in mid 80s, if athletes were injured, they went to the training room, and when they were healthy, they could come to the weight room. And there wasn't a lot of correlation between the strength and conditioning and the athletic training side of it. So I didn't understand the muscle system's role in pain or injury, and really I probably didn't understand function, when we're talking about function. And so that's what I want to bring today, because it was part of my evolution. I had a opportunity to work for a physical therapist after working as a strength coach, a physical therapist in Fresno that specialized in the biomechanics of movement. And the interesting thing is, with my chronic pain, one day I had him do an evaluation on me, and my back was bothering me, and he did a total body biomechanical assessment, and he ended up doing a mobilization on my big toe joint, my MTP joint. There was limited motion in my MTP joint. He mobilized my big toe, and for the rest of the day, my back didn't hurt. And I didn't really have an understanding. I'm kind of like, how can my big toe have anything to do with my low back pain? And let alone, like I said, I had the compensation and adaptation over the years where I had knee pain and SI joint dysfunction. So I had all these issues that all seemed to be related to that fractured vertebrae. And this guy comes in and he mobilizes my big toe, and I end up not having pain for a day. And so I started looking at it and started specializing in the biomechanics of movement and trying to gain an understanding of how the foot, the ankle, the knee, the hip, the trunk, all the way to the occiput, how everything's interrelated. And recognize that if you have abnormal motion at one joint, it can put increased stress on other joints and tissues up or down the chain. And so that was my quest, is to gain an understanding, a better understanding of the biomechanics of movement. And from a selfish standpoint, having the injuries and being what I would classify as dysfunctional by the time I was 25, I'm like, I need to understand this for selfish reasons also, because I need to figure out how to help myself. And so I sought out specialists from that point forward. And I sought out specialists that had, focus on biomechanics, that looked at the interrelationships of joints. And I literally remember at one point going to a medical conference that was on knee pain, and it was put on by physicians, and they were looking at basically the knee joint between basically the articulation where the tibia and fibula come in and connect with the femur. And it was like they only looked at the space between upper tibia and lower femur. And the whole conference for a weekend was just on knee joint function and the different injuries that can occur. And like I said, from a more medically based background. And it amazed me because the other end of the tibia is the foot, the other end of the femur is at the hip. And literally understanding the biomechanics, I came out of that weekend saying, how are they not looking at the foot and its relationship to knee joint function? And how are they not looking at the hip and its relationship to knee joint function? And so I realized that I was going down a path that we had a little unique understanding, because over time, as I understood more about the interrelationships of joints, I say literally the knee joint's a dumb joint. It's looking up at the hip saying, hip, you tell me what to do. Looking down at the foot saying, foot, you tell me what to do. And if those two don't agree, the knee's in the middle getting beat up. And so I started gaining this understanding and realizing that this integrated system was pretty complex. And when you have pain in one area of the body, it may be due to dysfunction in other areas of the body, like i.e. knee pain could come from problems in the foot and or the hip. And so that became my foundation of my understanding. And then I had the opportunity to learn from a great physical therapist named Gary Gray, who was, I would say, the king of functional movement. He still teaches courses in functional training to this day. And 30 years ago, I had the opportunity to go through all of his coursework. And as a non-physical therapist, at that point in time, he was only teaching his courses to physical therapists. And I basically had a great relationship, learning opportunity to work with him, combined with this Richard Jackson that I was working with in Fresno that specialized in biomechanics. And it gave me a good understanding of this integrated system in functional movement. And Gary Gray, like I said, is the king of functional movement, and he would challenge functional thresholds and identify imbalances in functional movement, and through literally functional training, try and create more balance through the whole integrated system. And so it was interesting, because if you're familiar with functional training or even the myofascial training basically now is a spin-off of the concept, not a spin-off, but kind of accentuation off of what Gary Gray's been teaching for years, that it is a whole interconnected chain, and myofascial chains, and they were focusing on the whole system through the myofascial system. But it basically, same concept, same principles. It's still an integrated system trying to transfer over into everyday life, or training of the integrated system to transfer it over into the function in everyday life. And so I worked with this for years, and I started becoming a specialist in the functional exercise. I did functional assessments and functional performance programs for athletes, and to the point, I was basically a range of motion functional specialist. And with this background, I've got me working. I got hired by the Utah Jazz through the end of the Stockton Malone era, and then eventually got hired with the Denver Broncos. So was working in pro sports with this background, coming from a functional standpoint. And then I developed MAT. And after I had experience with all of this, because I started realizing that as I was doing functional training, we'll work through this today, the principles of it, but as I was setting people up on functional exercises, I came with the question, like, am I actually strengthening people through their compensation patterns? And at the time I was working with high-level athletes, and working with high-level athletes, I always say you can do anything wrong with athletes and still have success with athletes, because the integrity of their neuromuscular system is so high that you just challenge their system, their body's going to adapt. But over time, even working in pro sports, I developed a clientele that, started working on the side, developing a clientele and seeing normal people. And now all of a sudden the functional training and the functional work that I was doing with these people, it wasn't having the same type of results. And that put question in my head. And probably one other thing that kept the question in my head was I was still broken down. I was doing all the functional training, everything that I was transferring to my clients, I was transferring the same principles and concepts to myself, but I'm still sitting here with patellofemoral syndrome, plantar fasciitis, SI joint dysfunction. I was still broken down. So ironically, I was dysfunctional as the specialist in functional movement. And so I started taking a deeper look. And one of the things that I can say in this whole concept is I was strong. I was working out. I was bench pressing close to 400 pounds, squatting 500 pounds, and I was strong, but I was broken down. And that didn't make sense to me. Like, how can you be so strong but still have injuries? And so I was trying to dig deeper into the whole principles. But one of the common themes that I saw in myself and other people that were in pain is they were chronically tight. Like after I had my fractured vertebrae, I could barely bend to touch my knees, let alone bend down to touch my toes. I was tight. And so as I sought out specialists in all fields, I went down the functional route, but what I said earlier, I was a functional and range of motion specialist, is every specialist I sought out, from chiropractic, physical therapy, podiatry, massage, training, every specialist I sought out that had a background in biomechanics focused on the idea that tightness is the cause of the problems. The reason I had all of these injuries is because I was tight. And so every modality, from chiropractic adjustments to mobilizations from a physical therapy standpoint, to stretching and deep tissue work from the massage and exercise professionals, every specialist focused on that concept, that you're tight. And the tightness is the cause of your problem. And so I understood the integrated system and how the foot, the ankle, the knee, the hip, the trunk, all the way to the occiput was interrelated. And then I realized that my tightness in certain areas could cause increased stress on other joints and tissues. So maybe this whole interconnected system was the cause of my problem is I had all these isolated tight areas of tightness that needed to be addressed. But every time I would stretch or get deep tissue massage, I couldn't get out of bed the next day because I'd have numbness and sciatica down in the big toe. And that took me to, I need to learn more. I need to understand more about the body. Even though I understood the interrelationships of joints, and literally I said to myself, why am I so tight? Like, it wasn't tight before I had the fractured vertebrae, and now I have everything tightening up. And I use the analogy like when you walk on ice. The natural neurological response is when the body senses instability, it will tighten up as a protective mechanism. So when we walk on ice, our body goes right into this protective state. Well, on the same standpoint, if there's instability from a neuromuscular standpoint, that neurological response is saying, I have to protect to provide an artificial sense of stability. And so then I took a step back and said, maybe this tightness has something to do with instability or weakness. It didn't make sense because I was strong. I'm bench pressing and squatting a lot of weight, and it's like, so I'm not weak. But it was like, but I was dysfunctional. And so that's where we're going to work off of on today's lecture, and kind of gain that understanding of looking at it, that there's certain, sorry, I change my screen here. There's certain focuses that all relate to trying to address the tightness side of it, but are we getting the results? Have you ever seen somebody stretch day after day after day, and they come back 6 weeks, 6 months later, and they're still as tight as they ever were? It's because we haven't melted the ice. And so we're going to talk about the principles of MAT and MAT and how it relates to functional movement, and looking at it from an isolated muscle function standpoint. So MAT is a biomechanically based process that's designed to identify and correct muscle imbalances that contribute to chronic pain or injury. So I'm a muscle specialist. I came from the background with exercise science, and I don't have a medical degree, but because of my back pain and the related issues that came with it afterwards, I started looking at the muscle system's role in chronic pain and injury. And in the process, after I looked at this and said, wow, I mean, maybe this tightness is due to some other underlying factor, an instability issue, I was able to put together this whole MAT process, which is a muscular-based process that addresses the muscle system's role in chronic pain and injury. And so as I went through kind of the evolution, it's recognizing that, wow, as a functional guy, I was doing all of this exercise, and I had some people, athletes would get better with it. And the question I had to ask was I making some of these athletes stronger in their compensation patterns? Because the body will get from point A to point B most efficiently with what it has to work with. So yeah, if you have weaknesses in the body has to, other muscles have to jump in. And that's one of the greatest things about the body is you can have weaknesses in one area of the body and it can pull in other muscles to make up for the weaknesses and still get you from point A to point B as effectively as it can with what it has to work with. Well, the athletes had a lot to work with. They were strong, and they may have some imbalances throughout their body here and there. But as I started dealing with more dysfunctional people, I always say there's a certain point in time that people no longer have enough strong muscles to compensate for their weak muscles. And that's the time when Pandora's box opens up. You have the straw that breaks the camel's back and they can never get healthy. And so my question was, even though I was having success with a functional application or application of functional movement and functional assessment, as I got further away from the athletic world to the more dysfunctional client, I wasn't having the same type of success because exactly what I said, they were dysfunctional. So their integrated system wasn't functioning very well. And the integrated system, the way I look at it from an MAT standpoint, is the integrated system is only as good as the function of its isolated parts. So that's when I started looking at more of the isolated component of it and saying, well, if there's weaknesses or tightness in certain areas of the body, how is that impacting movement in other areas of the body? And so started looking more at the isolated standpoint, and that, like I said, that was when I developed MAT. And regardless of whether I was looking at it from an isolated standpoint or if I was looking at it from an integrated functional standpoint, the goal of anything that I was trying to do was improve the functional capabilities of the clients that I was working with. And so if functional training, the goal is to improve functional movement or integrated movement. In isolated training, the goal can be the same thing. But you have questions, can you get the transfer? If you have isolated strength and through muscle, and you train muscles from an isolated standpoint, will you get the transfer the minute you get somebody off the table and put them on the ground? Will you get that transfer? And early on in my career, I believed that they had to be on the ground. You have to strengthen them functionally because that's the way we move, that's the way we function. And then as I developed MAT, and we go through this today, we'll start to see that the integrated system is only as good as the isolated parts. And if you give the body more to work with, it will function more effectively when the foot's on the ground or when we're weight bearing. So the goal is to improve functional capabilities. So this woman was a woman that came to me, diabetic, kidney transplant, in chronic pain. And literally, I always say, literally, I don't care what you can do. I want to know what you can't do, because what you can't do is breaking you down. So from a functional standpoint, like we asked the question, what is function? And she needed a function in everyday life. And she tells me the story that she was down on her knees in the kitchen, and she bent down to get something up, pick something up, and she couldn't get back up. She had to have her grandson help her stand up. Well, that's dysfunctional. And so I said, well, let me see what you can do. And this is the woman. I had her do what she was trying to do in function, and it was stand up. Go. And look at this woman trying to stand up. She's using anything and everything she can to try and stand up. That wouldn't be classified as functional. And so the key is, I mean, I said the body will get from point A to point B most effectively with what it has to work with. This is her just trying to using anything she has to stand up. And the interesting thing about this woman is she was chronically tight, like every muscle in her body. I checked hip flexion, hamstrings, quadriceps, hip rotators, trunk rotators. All the muscles in her body were tight and protected. But the interesting thing, she was doing these stretches. She was doing stretching protocol 2 to 3 times a day that she was given through her physical therapy. But this was her coming in. And I guess I'll ask that question, do we ever think that stretching can improve function? I mean, will stretching make her stronger? You may be able to increase flexibility even if it's temporary. You may be able to increase flexibility, but will stretching actually make her stronger? And so this is her coming in the first time I saw her. In the same day, this is the same woman standing up. Look how much more efficient that motion is. And so one of the things that I said is this woman was chronically tight. So she goes from not being able to stand up, to efficiently being able to stand up. That was improving her functional capabilities. So the transfer, and basically when I assessed her, she was limited in her range of motion. But she was telling me that limitation in range of motion was due to weakness. She had an instability problem. We're going to talk about that, is what causes this. And I'm kind of putting the cart ahead of the horse, is the principles of MAT is she had isolated weaknesses that were causing her protective tightnesses. And everyone had been focusing on the tightness with her. And we actually, the first day she came in, we addressed the weaknesses, and immediately it improved her overall function. From an isolated standpoint, we were able to improve integrated movement. And so basically, I said earlier, the body will get from point A to point B most effectively with what it has to work with. She didn't have a lot to work with on the slide on the left side. We gave her a little bit more to work with, and she was functioning more efficiently. So the transfer was immediate. Getting muscles activated, i.e. muscle activation technique, getting muscles activated from an isolated standpoint was able to help her improve her overall function, her functional capabilities immediately. And so we think about, I have that word compensation, we'll talk about that. So now let's go to the idea again, what is function? This is the other end of the continuum. I don't have a video there, but this is a guy, I mean, he's functional. I mean, what would it take for that guy to I mean, swing on the rings like he does? He's got to have muscle strength and muscle stability. Imagine if his muscles were not, and that support the shoulder joint, were not stable and couldn't support the shoulder. Imagine if we put that woman in on these rings. She'd end up dislocating her shoulders. Her body would be on the ground while her hands are still hanging onto the ring. She'd be, I mean, she wouldn't be strong enough and stable enough to perform any motion like that. So this is the other end of the continuum. And that's what I realize is athletes can have isolated weaknesses, but they're strong enough to compensate for their weaknesses. So even if this athlete has some weaknesses, his body's strong enough and trained well enough to compensate for the weaknesses. The woman wasn't strong enough to compensate for her weaknesses. And like I said, she was in chronic pain. And the problem was her muscle system was so weak that, I mean, it took everyday activity was too stressful on her system. This guy is the other end of the continuum. So he would have a positive effect from functional training, where the woman, we had to go back and go to the isolated parts and try and improve the function of the isolated parts so that the integrated system could function better as a whole. And so we move on, and that's basically, and that's where MAT came in, is looking at the idea that the integrated system is only as good as the function of its isolated parts. And that woman that I showed you, we could have her doing functional training to try and improve her function, and all we're doing is reinforcing dysfunction. So I always say if functional training reinforces dysfunction, then how functional is it? As opposed to the idea that as you give them more to work with, you can strengthen them through the functional training. So MAT, getting the isolated parts working, can create a positive transfer into integrated or functional movement. So you get the body prepared for functional training. Get the isolated parts working, and then the integrated system will function more efficiently as a whole. And so the key is I talked about compensation. When you have muscle weaknesses, the body has to compensate for those weaknesses. The body will get from point A to point B most effectively with whatever it has to work with. So if you have weaknesses throughout the body, because function's about timing. You think even in your gait cycle from heel strike to same side heel strike, it happens in less than a second. And so function's about timing. The muscles have to be able to contract and contract on demand. And if they can't contract on demand, it's like by the time you already, go to the next heel strike, if those muscles weren't involved, they've missed the boat. And so the body has to compensate for those weaknesses, and other muscles have to jump in and make up for it. And you saw that happen with the woman. She was pulling in anything and everything she possibly could from a muscular standpoint to try and help herself stand up. And part of that had to do with pushing up with her arms on the table. So then we gave her more to work with. So she was compensating for her weakness. And when I gave her more to work with by activating muscle weaknesses, immediately she could stand up more efficiently. So she didn't have to compensate as much. But the interesting thing about compensation is if you have weaknesses, compensation is a good thing until you fix the problem, because the body has to get from point A to point B. So it will get there most effectively with what it has to work with. The goal of MAT is to give it more to work with. And now I go back to the idea when I was doing all the functional training. It's like driving your car with bad alignment. And the harder and faster you drive your car with bad alignment, the faster it's going to break down. And so I realized with the exercises that I was giving people, the functional exercises, it was making them stronger. They appeared to be more functional. They were stronger through their functional movements, but basically the strong were getting stronger and the weak were staying weak, and we were magnifying the imbalances. And those imbalances, it's like driving your car with bad alignment. Those imbalances can eventually catch up with you. So the goal is go identify the weak links, because we're only as strong as our weakest link. Identify the weak links, and then you get those muscles activated, then you give the body more to work with from a functional standpoint, from an integrated standpoint. So it's not whether or not isolation or integration, one is better than the other. It's like the integrated system is only as good as the function of its isolated parts. Just give it more isolated parts to work with. And that goes back to the basic principles of MAT. With MAT, we take an in-depth look at isolated muscle function. I don't care what you can do. I want to know what you can't do, because what you can't do is breaking you down. And you think about it just from a shoulder joint mechanics standpoint. The complexity of an integrated movement of just somebody lifting their arm into shoulder flexion. What has to occur to create that motion? We'll go into abduction, as you see in the picture, but shoulder flexion and abduction, you have glenohumeral motion, you have scapular motion. You actually have to have spinal extension in order to get full range of motion at the glenohumeral joint. So you have motion occurring in multiple joints just to lift your arm up over your head. And whether it's abduction or flexion, you have motion occurring in multiple joints. And muscles have to be contracting and contracting on demand. And so you look at the picture on the upper left, and you see the supraspinatus and the deltoids. They initiate the movement of abduction. And then as you initiate the motion of abduction, you have glenohumeral, majority of glenohumeral joint motion at the beginning. Then the scapula has to move. So the scapula has to upwardly rotate. So for every 3 degrees of, for every degree of scapular motion, you have 2 degrees of glenohumeral motion. So if I go to 90 degrees of abduction, I have 30 degrees of scapular upward rotation of the scapula and 60 degrees of motion in abduction at the glenohumeral joint. All of that has to occur at the right moment in time. And so if you can see my hand, and my hand's going to be the scapula, I'll be the scapula, the axis of motion of the scapula goes right through the superior angle of the scapula. So I said, as you lift your arm, you get upward rotation of the scapula. Well, muscles move bones. Muscles move bones and muscles hold bones in proper alignment. So the axis of motion, and as we initiate abduction from 0 to 90 degrees, the axis of motion is at the superior angle of the scapula. And so the upper serratus and the upper trapezius that have the mechanical advantage because their insertions are far away from the axis are what initiate this motion of upward rotation of the scapula. And then as we get to 90 degrees of abduction, you get tension on the acromioclavicular ligaments, and now all of a sudden the axis of motion shifts from the superior angle of the scapula to the AC joint. And now all of a sudden that allows the inferior angle to wing more and open up range so you can fulfill that whole range of abduction or shoulder flexion. And so all of this has to occur at the right moment in time. I said through the superior angle of the scapula, you have the upper trap and the upper serratus initiating the motion. And then as the axis switches, it switches the muscles that have the mechanical advantage. Now the lower trap and the lower serratus have more of a mechanical advantage to continue that motion about the new axis. So we have a shift in muscle function. And think about it, this all has to happen at the same time the rotator cuff muscles are holding the head of the humerus and the glenoid, and all of these muscles have to be contracting for me to do this. So now you think about it, if somebody, the levator scapula actually comes right into the superior angle, so at that first 90 degrees of abduction, levator scapula is a muscle that actually stabilizes the axis, creates stability about that axis. But imagine if you have a weakness for whatever reason, say the upper serratus can't do its job to pull the scapula, the medial border of the scapula out, all of a sudden the upper trap becomes dominant, and instead of creating rotation, it creates elevation. Now the levator scapula says, oh, I'm pulling there too, but I used to be a stabilizer, but now the axis of motion changes and it becomes elevation rather than upward rotation. You ever see people lift their shoulder and they elevate their scapula and they can't get their arm over their head? It's because muscles aren't firing the way they're designed to fire. For this to happen, every muscle has to fire at the right moment in time. The lower or upper serratus and upper trap have to be, able to fire and fire on demand to initiate upward rotation. The lower trap and the lower serratus got to jump in and create that final 30 degrees of upward rotation as you go from 90 to 180 degrees of abduction. So they have to fire and fire on demand. So function is about timing. Imagine if the timing is off. If the rotator cuff muscles aren't doing their job to hold the head of the humerus in the glenoid, it's like having loose hinges on your door. It becomes all rackety, and the next thing you know, you have a labral tear or you have impingement syndrome because you don't have stability through motion. So the integrated system, for me to go through this integrated motion of shoulder flexion or abduction, the integrated system is only as good as the function of its isolated parts. You can't strengthen these isolated parts through exercise because they have to be able to contract and contract on demand. And so we look at that, again, function is about timing. When you have stress, trauma, or overuse to the muscles, the resultant inflammation negatively affects the ability for those muscles to contract. When muscles can't contract effectively, they can't shorten effectively. When muscles can't shorten effectively, the opposite muscles can't lengthen effectively. So the opposite muscles will show up as being tight. And I talked to you about after I had the fractured vertebrae. After I had the fractured vertebrae, I was chronically tight. Well, this tightness was due to the resultant inflammation that negatively affected my ability for muscles to contract. And when you have inflammation, the inflammation negatively affects the slow twitch muscle fibers. And the slow twitch muscle fibers are the muscles that maintain upright posture, and they contract on demand. They basically contract beyond our conscious control. And they are negatively impacted by inflammation. And basically they change, when you have inflammation, it changes the metabolic characteristics of the slow twitch fibers to the point where the threshold to activation gets higher. So it needs more electrical current before you can get contraction. And the best way to explain it is when you have inflammation that alters muscle contraction, it's like having loose battery cables. The nervous system sends input to the muscles and they just don't, they're kind of sluggish. They just don't fire, and they don't fire on demand. which means they can no longer do their job to stabilize joints, and they can no longer do their job to protect you from injury. The timing gets thrown apart or gets disrupted. The muscles can't contract and contract on demand, and when you need muscles contracting and contracting on demand, like that woman, she was sluggish. She needed muscles to be able to contract and contract on demand. The minute she had the ability for more muscles to contract on demand, she could stand up more effectively. So she was actually stronger because we activated the muscles that were negatively impacted by inflammation and the slow twitch muscle fibers. I told you I was strong, but I was unstable. I was strong. I could bench press and squat a lot of weight, but I didn't have stability through motion. It's not the fast twitch fibers that holds joints and keeps stability through motion. It's the slow twitch fibers, because that stability has to happen beyond our conscious control. And so it's a paradigm shift that the integrated system, when we exercise, the strong get stronger and the weak stay weak, because the ones that are firing will fire. And they'll get stronger. The ones that aren't firing, they're just along for the ride. They're sluggish. And so that's the key behind MAT. In this whole integrated motion, and the reason that you can see somebody like working way too hard to get from point A to point B, like that woman was, is like because the muscle system is just sluggish. The nervous system can't get input to the muscles, and the muscles can't fire on demand, and that's why that woman was chronically tight, and then she was had chronic pain. So the goal is you have to prepare the body for what you're asking it to do. So thinking of that is, it's like loose battery cables. You look at this, and this is a vastus medialis. You have 4 different divisions of the vastus medialis with the VMO at the bottom, and then 3 other divisions, all separated by fascia. And you think about that as each one of those divisions is separated by fascia has its own set of battery cables. And muscles have basically their own communication. Each division of the muscles have their own communication pathways with the central nervous system. And the goal is to make sure that the communication pathways are intact, that you have tight battery cables. And when all the muscles are, you got tight battery cables and all the muscles can fire and fire in demand, we can function at a high level. So the foundation to MAT is looking at this idea that muscle tightness is a representation of muscle weakness from an isolated standpoint, that the loose battery cables are the cause of muscle tightness. The altered communication between the nervous system and the muscle system, where the muscle just can't fire and fire on demand, causes the body to go into protective tightening, just like when we walk on ice. Why do we tighten up when we walk on ice? Because it's a protective mechanism. If I gave you a muscle relaxer and took away your protective mechanisms, the body would, you'd slip and fall and injure yourself. Well, the same way the body knows that it has to tighten up and protect when it has instability. And their interesting part and component, which is a deeper issue, is that those instability issues are in the extremes of range of motion. So the body protects you from moving into the extremes of range of motion, where it's the most vulnerable when you have muscle weakness. Because when a muscle can't contract efficiently, it can't shorten effectively. And it can't shorten effectively, then it's not going to be able to tolerate forces in those extremes of range of motion. So the body tightens up as a protective mechanism. Inflammation causes the muscles to tighten up because of the weakness related to the inflammation. And that's all based on the principles of reciprocal inhibition. In reciprocal inhibition, we look at reciprocal inhibition, when a muscle contracts, it's basically we're looking at the sensitivity of the muscle spindle and the associated muscle. And if you look at this picture, when the bicep contracts, you have sensory input that goes back to the spinal cord. You see that 1A afferent axon going back, and it synapses with the alpha motor neuron of the bicep itself. So it reinforces the activation and contraction of the bicep. But that red 1A afferent axon also synapses with that black neuron in the spinal cord, which is an inhibitory motor neuron. And that inhibitory interneuron basically is going to inhibit the axon or the neuron that it's synapsing with, which is the motor neuron for the tricep. And so the tricep actually inhibits when the bicep contracts. So reciprocal inhibition is actually a component of our normal functional movement. It basically says when my bicep contracts, there has to be an inhibitory aspect sent to the opposite muscle so that the tricep doesn't get in the way. Imagine if my bicep and tricep were contracting equally, I'd have an isometric contraction because I wouldn't be able to move because the tricep would resist me from moving into elbow flexion. So here, the bicep contracts, sends reciprocal activation to the bicep to reinforce the contraction, while it inhibits the function of the tricep so that the bicep can contract to its full range of motion. When you have stress, trauma, or overuse, the resultant inflammation alters the ability for that muscle to contract, so you have less sensory input. You have less input from the muscle spindle, which means that you have less input to reinforce the contraction of the bicep, which means it's weaker. And then 2, to reinforce the reciprocal inhibition to the tricep, which means now the tricep doesn't inhibit. So it shows up as being tight. Based on the principles of MAT, and based on the principles of reciprocal inhibition, when you have stress, trauma, or overuse, the resultant inflammation alters the communication between the nervous system and the muscle system. So the one muscle, the agonist muscle, i.e. the bicep in this case, loses its ability to contract efficiently. You lose that reciprocal inhibition, and then the opposite muscle shows up being tight. So tightness is a sign of weakness due to that stress, trauma, or overuse. So with muscle activation techniques, wherever we see a limitation in range of motion, it's not because the muscle that is tight is the problem, it's the opposite muscles. When I told you I couldn't bend down and touch my toes, I stretched my hamstrings and I stretched my erector spinae muscles, and I told you anytime I would stretch or get deep tissue massage, I couldn't get out of bed the next day because I had numbness and sciatica down into my big toe. And it was like, well, what was wrong with me? Well, the problem was the opposite muscles. Think of the opposite. Hip flexors, hamstrings and erector spinae were tight, which meant the hip flexors and abdominals were weak. And the first time I got my hip flexors and abdominals activated through muscle activation technique, I reached down and touched my toes for the first time in 10 years. It took away the protective tightening. So the goal of MAT is to melt the ice. Provide a sense of stability, and the body will give you all the mobility in the world. So in the principles of MAT, range of motion becomes an indicator. Wherever you see a limitation in range of motion, it tells you that one or more of the muscles that move you into that position are potentially weak. And with MAT, we have the tools to perform isolated muscle testing to see where are these loose battery cables. I don't care what you can do. I want to know what you can't do, because what you can't do is breaking you down. And that's what we'll find is that, okay, there's a lot of muscles that are involved. There's actually over 21 divisions of muscles just in the shoulder complex itself that have to do the right thing at the right time just to lift your arm up over your head. And when people can't lift their arm and they're dysfunctional in the way that they move themselves, it's because those muscles aren't contracting efficiently. And the strong get stronger and the weak stay weak, and anything you try and do to strengthen it just reinforces those imbalances. So again, any place you see a limitation in range of motion is because one or more of the muscles are potentially weak, and that has a huge impact on functional motion. Now that's what we want to talk about. Again, we'll go back to that integrated system and my understanding of function, that the foot, the ankle, the knee, the hip, the trunk are all interrelated. And if you have abnormal motion or stability at one joint, it can negatively affect motion at other joints above and below. And the integrated system is only as good as the function of its isolated parts. So if we understand isolated muscle function, we can gain a better understanding of integrated or functional movement. And so I'm going to use one example here, and then I'm going to transfer it over here into practical application here on the table. I'm going to show you an example of isolation versus integration. That the integrated system is only as good as a function of its isolated parts. One of the common things that I see on many clients is limitations, and tight calves, limitations in ankle dorsiflexion. Well, dorsiflexion is required for normal functional movement. We stand, the foot's the first thing that hits the ground. When we function, the foot's on the ground. And so the foot's the first thing that hits the ground, and the rest of the body has to react to what the foot does. So if the foot is not in the right position, it affects motion all the way up the chain. And we know it conceptually because people are getting put in orthotics, on a regular basis. And people are being put in orthotics because they're pronated, and it can cause knee pain or hip pain, or excessively pronated, causing knee pain or hip pain or shoulder pain. And as well, that's a foot problem. But the foot's complex. And literally, if you have a limitation in range of motion in ankle dorsiflexion, I'm going to grab a foot. And if you have a limitation in ankle dorsiflexion, it means that as you come over the fixed foot, with the foot on the ground, the tibia can't come forward. They say you need 10 degrees of dorsiflexion for walking, 20 degrees for running. Common theme, I see people with limitations in ankle dorsiflexion when we truly check talocrural joint motion and don't allow compensation through the subtalar mid-tarsal joint. I see people with limitations in range of motion where they're actually 30 to 40 degrees plantar flexed in the neutral position of the foot, which means if they stood up, their heel would be that far off the ground. And if their heel was that far off the ground, and if they didn't compensate for that limitation in ankle dorsiflexion, that's how they would stand up. They'd stand up with their heel off the ground. So basically, the body has to compensate. When it stands up, dorsiflexion is a sagittal plane motion. Through the midfoot, you can get sagittal plane motion. Through the oblique axis of the mid-tarsal joint, you actually get a 1-to-1 ratio between transverse plane and sagittal plane motion. So if you can't get motion in ankle dorsiflexion, you get motion through the oblique axis of the mid-tarsal joint. But because you get equal motion in transverse and sagittal, the foot goes up and out and the leg goes down and in. That's called pronation. So some people have to pronate just to stand up. And if you start from a bad position, you can never get in a good position. And so just tight calves can cause people to start from a bad position from the ground up, and that puts increased stress all the way up the chain. And this is a common limitation because of shoe wear and wall-to-wall carpet, and we basically accommodate lower leg and foot muscle. But again, why is there this limitation in range of motion? Tight calves. If you see tightness or a limitation in range of motion, it's because the opposite muscles are weak. So the anterior tibial muscles, from the anterior tib to the peroneus tertius to the extensor digitorum and the extensor hallucis longus, the muscles that are anterior to the axis are the muscles that create dorsiflexion about the talocrural joint axis. And so is it the tight calf due to the weakness on the opposite side? Many times we focus our strengthening programs on plantar flexors. We do calf raises, but we don't balance them out with anterior tibial muscles. I don't see a lot of people doing anterior tibial training, and those are where you see common weaknesses. And the body will get motion wherever it's available. If you can't get it through the talocrural joint, you'll get it through the oblique axis of the mid-tarsal joint, and you'll have excessive pronation just to stand up. And now I'm going to show you an example of that. Here's a woman that was limited in ankle dorsiflexion. And I think I can hit the screen here. There. I'm checking her, I'm locking her forefoot to the rear foot, so I'm only assessing talocrural joint motion, and she doesn't even get back to perpendicular. She's actually about 30 degrees plantar flex. So this is her standing up. Remember, if she can't get back to neutral, she's got to pronate just to stand up. Oh, geez, sorry. So again, here's her limitation in range. It doesn't get back to perpendicular. So her heel has to get on the ground. So in order for her heel to get down on the ground, she has to pronate. Look at with her standing up. She barely started to squat and her knee is pointing inward. What did I say? The foot gets pushed up and out, the forefoot relative to the rear foot goes with the leg, and that goes down and in. So her knee's pointing down and in. If you start from a bad position, you can never get in a good position. She's pronated before she even starts to move. Watch her try and do a one-legged squat. She's doing anything and everything she can to stop her knee from diving in because she's starting at a mechanical advantage because she had weak anterior tibial muscles. We ended up treating the anterior tibial muscles. She's pretty much perpendicular. She's a couple degrees shy of being perpendicular, so her compensation is going to be less because now she doesn't have to pronate as much to stand up because her heel, she was about 30 degrees plantar flexed in the first video. This is the same woman the same day. after we improved their anterior tibial muscles. The anterior tib, peroneus tertius, extensor digitorum. Look how fluid that motion is. We changed her functional movement. We improved her functional capabilities by activating isolated muscles. The integrated system is only as good as the function of its isolated parts. And when you have people, that's just an example of one group of isolated weaknesses, which is the anterior tibial muscle. This happens throughout the body. If you have isolated weaknesses, the body's going to have to compensate for those weaknesses. So the goal with MAT is to go through and identify where those isolated weaknesses are. And the greatest part about it is limitations in range of motion tell us where isolated weaknesses are. So now I'm going to shift back to full screen. So going to the big foundational principles is wherever you see a limitation in range of motion, it tells you that one or more of the muscles that cross that axis are potentially weak. So what we do with MAT is we do range of motion assessments, not to see what's tight, but to see what may be potentially weak. And prior to checking, I went through and I checked his hip internal rotation. How many times do you see with athletes the limitation in hip internal rotation? I'd go to the other side to check, but just as I use it, as I go through range, they say he's got much more motion on the left side than he does on the right side. So there's a limitation in range of motion in hip internal rotation. I used to strap people down and stretch, their external rotators and PMF stretching, contract relax, trying to do anything possible to increase that range of motion. And I'd see with a goniometer, I'd see like 2 or 3 degree change in range of motion. He has a limitation in range of motion and internal rotation in his right hip. Well, that means that one or more of the muscles that move you into that position are potentially weak. So what muscles create internal rotation at the hip? Turn around the other way. I'm going to stay on this side. So I'm going to test. We got muscles. We got, I'll be out of the picture, but we got rectus femoris has a component of internal rotation. Hold up. So we perform muscle testing. Tension fascia lata, hold up. Anterior gluteus medius, hold out. Oop. Look at that. As I go anterior gluteus medius, he's weak. The more I push, the weaker he gets. And see how he rubs his side? It's like, well, that didn't feel good. So, literally quickly go to the origin insertion where there's the greatest density of sensory receptors and the muscle spindle fibers. And we go in and we basically go to the origin insertion. I'm doing this quickly. And that was the anterior gluteus medius. And I'm sorry, anterior gluteus minimus. I actually moving too quick. That's the anterior gluteus minimus. So coming more in the midline of the pelvis, different insertion. Come in, hold out, and all of a sudden he's strong. He can withstand forces now. And that's one of the muscles. I say, I don't care what you can do, I want to know what you can't do, because what you can't do is breaking you down. And it's causing a protective tightness. So one out of the muscles that I tested, the rectus femoris was strong, the tension fascia lata was strong, but the anterior gluteus minimus was weak. Now check anterior gluteus medius, and that's strong. So we find what's strong and what's weak. Well, I don't care what you can do, hold out. And ironically, we got another weakness here. This is a vastus lateralis, which actually, when a weight-bearing standpoint, has a component of function and internal rotation at the hip. And got a weakness in the superior division of the vastus lateralis, palpating the origin insertion. The mass of the quads run all the way up the leg to the posterior side. Hold out. And then he's strong. Hold out. Different divisions of the lateralis. He's strong. Turn back around. The other way. This is just a quick example of what we're looking at. So then we got the muscles. There's abductors that rotate, internally rotate the hip, abductors that rotate the hip, the quadriceps rotate the hip. We have many muscles that have a component of function in hip internal rotation. This is just one movement in the body where I found a limitation in range of motion. When we get done, relax. His range of motion, his range of motion increased. And so I don't need a goniometer to sense it, but he probably has a 5 to 10 degree increase in range of motion in hip internal rotation after getting the internal rotators activated. So that's going to transfer. The integrated system is only as good as the function of its isolated parts. And we're doing this in a quick video and a quick summary of analysis, but wherever we see a limitation in range of motion, with MAT principles, we have the ability to test and treat all the muscles associated with that movement to tighten battery cable, to restore neuromuscular function. Like that woman, as more muscles can contract, functional movement improves. So those are the quick hour session here today. Those are the foundational principles behind MAT, and the concepts became isolation and integration is the integrated system is only as good as the function of its isolated parts. And with MAT, we have education programs that teach these principles throughout the body. If you're a practitioner that's a shoulder specialist, like I said, just to lift that arm, all these muscles have to contract at the right moment in time. Back specialist, the principles are all the same. I couldn't bend over and literally the muscles that were moving me into trunk flexion were the muscles of trunk and hip flexion, were the muscles that were weak that caused the tightness in the hamstrings and the erector spinae. The foot, we saw the way this girl changed her functional movement just by improving the muscles that dorsiflex her foot at the ankle. His principles are true throughout the body. We have education programs. You can reach out through MAT and find out more about the areas of specialty and where you would, courses you would like to take if you're interested. But more than anything, it's recognizing these concepts, that we are only as strong as our weakest link. So how do we identify and correct weak links in the body? And I think from my experience, MAT is a powerful tool to be able to do that. I think we're out of time here, so thank you very much for being here for the hour. Good luck with everything with this coronavirus, and hopefully everybody gets back to work and back to what we want to do on a day-to-day basis, and that's help people. So thank you very much. Thanks for your time.